Okay, so moving on, whirlwind tour. Understanding professions, very crucial inputs of health care. Who is the most powerful professional in the health service? It's not a trick question. Yeah. The concept of a profession is interesting, isn't it? Weber had a really nice criteria, definition, description of a profession. Characteristics. He said they have a body of specialized knowledge. If you think about the doctor or the pharmacist, yes, they're very knowledgeable. They're respected for their knowledge. How many years of training? 7, was it? To even qualify, and that's not even specializing. To be able to sign that prescription notes or say doctor or something, or give you advice on your medicines. It's so long a training. Monopoly over practice. In England, we have a general medical council. You have to be registered to practice as a doctor. Similarly, there are registers for nurses and pharmacists. Not anybody can be a nurse. Can't be like, oh, I'm a nurse, I'm going to come and work in your hospital. No, you have to be certified, you have to be registered. Is that the same in Japan? Yeah. Code of ethics. A lot of doctors, before they start practicing, they take an oath. Is there something like this in Japan as well? And a degree of altruism. So this is what Weber said is a profession. And it's really helpful for us to understand that level of degree of power, degree of autonomy from a profession. We know because, in the medical profession has come to dominate the healthcare service for reasons that we've talked about already, different historical influences and also professional expertise. There they derive professional power, technical expertise, authority and autonomy. The third one's really interesting, clientele. It is that particular relationship that's really special. And it's not unique to doctors, pharmacists have it as well. And that unique engagement and personal relationship based on trust between the patient that comes and seeks your advice and that professional that gives that patient a professional advice. Crucially, uncertainty. Health is an agency relationship. We would come to discuss that. There is uncertainty over what I need and what the outcome is. And so I actually want to seek advice and the advice of experts. And actually it's getting rare in modern day for us to want to seek advice. There's a rhetoric in a bigger society about, done with the experts. We don't want to hear about experts anymore. We've got social media, we've got news updates, news feeds. But actually, health is still quite unique in that we actually do care about the advice of the experts, for my health at least, for your health. When you're a patient, you want to be in that position to seek advice. And so it's very interesting to understand the power and how power comes from deriving. And you will come to see that power is quite core as to a lot of why the health services are the way they are, from the influences that we briefly covered this morning. We talked about regulation and peer review, and some of these processes propagates the power of the profession. For example, subjugation. Usually there's a hierarchy within medical structures. In England, at least, medicines are very hierarchical. In the past, I think this is slowly changing. In the past, there's also, doctors are seen as, you can tell the nurse what to do, more or less now, but there's subjugation of other professions. Limitation, so, you can't practice unless you're registered. As a medical doctor, we can't practice dentistry. I can't look into people's mouths and go, I'm going to take your teeth out. There is limitation on what we can do. Exclusion as well. We say what is medicine and what is not. Allopathic medicine is medicine, but osteopathy, homeopathy, that's not medicine. acupuncture, let's call it complementary medicine. So there's a strict criteria and exclusion of things. So that propagates this power of professions. Slightly moving on to a quick topic, just so that we're aware that healthcare is a large employer of staff, but also a huge employer of force of mobilization internationally. And there are, the workforce is important, and there is a high income, low income shift to push-pull factors. And inequalities do come from the global health care workforce as a result of migration of these resources. It's a nice little diagram talking about migration of health workers, just to be mindful that the inputs that make up the health services are crucial. Finally, just to finish off, the users of healthcare. Who are these? The patients. Very crucial. There are different models, and we briefly touched on it already, of healthcare delivery. But it comes to see the dynamics between the interaction we talked about between the doctor and the patient, and how of the relative power of those patients. And tomorrow in our seminar, we're going to do a little bit more deep dive in looking at that agency relationship and looking at that relative power interaction. But first of all, we have the traditional model of users as patients. And this is where the doctor says it. Tells me to take a tablet, I take a tablet. I am here to seek the advice of the healthcare profession. And I am a patient, and I have my sick role, and I defer the decisions to the doctor. And the doctors have full autonomy, and they advise and give treatment. So this is where the patient, the user is seen as a patient. Then, increasingly, we are seeing users as a consumer, and certain more so in market models of healthcare, where patients are the consumers, and they have choice as to where I am actively informed purchasing this healthcare. I think this surgeon's better for my knee replacement. I am going to go to this hospital because the outcomes are better. I want surgeon X. He sounds good. He's famous. I'm going to go to surgeon X for my treatment. These are as informed as possible, but these are consumers making an active choice. I want this Apple TV, and I want that phone. Right? I don't want this phone. These are consumers. It's a similar kind of model, and increasingly, there are aspects of healthcare which we're seeing this choice in consumers. So these are users who make informed choice. In some countries in Europe where they have social insurance, public can choose the packages of healthcare they want, and they compare the prices of the different insurance, and they make a choice. They say, oh, this is cheaper, I'm going to go for them. So that's a choice. And then there's the third, which is increasingly in the conversation, where users are citizens. What does that mean? Well, in a kind of more broader sense, we know that in a lot of health promotion activities where actually citizens have to be consulted. There's the activities of healthcare that actually citizens lobby and haven't. Well, I really like my hospital. No way you're shutting that down. I know our A&E is small, but we like it. We like it in our doorstep. We're going to have it. So these are very informed lobbying. Members of the public, patients who actually are participating in healthcare issues, are well informed, are discussing in a dialogue. They're defined, and they have sharing collective experiences. It could be a disease community, a diabetic community. They may want to shape diabetic care in a certain way. They could become very influential, and the governments listen to them, and they have meetings. So these are users as citizens. We talked about a lot of this already. Shaping healthcare delivery, community model. Yes, so that's the name of the models given to the different roles of users. And that is my last slide. Thank you very much.